Okay, so we're going to pick up where we left off last time. I apologize. We had a little bit of technical difficulty there, but this will be part 2, continuation of chapter 15. So we left off with talking about the general management guidelines. So when you have someone who is in the acute stage of recovery from any type of spinal type pathology, there's going to be a decent amount of patient education involved in this time. Teaching them safe postures that they should maintain, what they should avoid, if there's any precautions, anything like that is going to be included. Teaching them in proper exercise technique, things that they can continue on with either in therapy or at home. We want to decrease their acute symptoms. So really this is managing their pain, and this is where modalities can come into play. So we've discussed traction already. If that appears to be appropriate for your patient, you can certainly use that. But heat, ice, e-stim, ultrasound, all of those may work as well to just get your patient feeling a little bit better. Teach your patient awareness of neck and pelvic position and movement. Again, postural awareness, if that's contributing to any of their issues. Demonstrate safe postures. Initiate neuromuscular activation of stabilization muscles. So we'll get into some of the specifics of how we do that as we get a little further into this lecture and the next one as well. And teach your patients safe ways to perform their ADL so that they don't exacerbate their problems. Once your patient moves into the subacute phase, generally they should be feeling a little bit better by this point, so modalities are typically no longer indicated, and we want to teach the patient self-management skills. So we don't want them to have to rely on us or coming into therapy in order to help manage their symptoms. We can continue to progress in awareness of that spinal alignment, teaching them proper postures. Hopefully they're getting better at being able to maintain them on their own at this point. If there's any restrictions in muscles, joints, fascia, nerves, we should address them at this point. You also want to teach your patient techniques to develop neuromuscular control, strength, and endurance. So hopefully we've been teaching them the techniques during the acute phase, and at this point it's more of a strengthening and endurance type activity. So we're really trying to fine-tune and trying to progress at this point. We can typically begin some cardiopulmonary endurance activities at this point. Usually in the acute phase, they're too painful to participate in a lot of aerobic type activities. So we can start to add those back in the subacute phase. We may teach the patient some stress reduction or relaxation techniques because we know that stress is going to add to their issues typically, and continue to teach safe body mechanics, especially if we are trying to get them back to function, work, recreation, those types of things. So then as we move into the final phase of rehab, the return to function or the minimum protection phase, again, we're going to emphasize that spinal control, but now do it in a functional way. So not only do they need to be able to know how to activate those muscles and have the strength and endurance to maintain the activation of the muscles, now they need to be able to maintain that activation while they're doing whatever it is that they need to be able to do. So high intensity, repetitive activities, what sort of things do they need to be able to do, and can they maintain that spinal posture in those activities? Increased mobility, again, in any muscles, joints, nerves, and fascia that might still be needed. Again, hopefully we're past that at this point, but if not, continue to address those issues. We want to continue to improve muscle performance. We want to make sure that we're doing dynamic trunk and extremities strengthening, coordination, posture correction, again, teaching them the skills that they're going to need in order to maintain on their own. Safe progression to high-level activities, and healthy exercise habits for maintenance. So I included this picture over on the side. It's showing different planking activities, but it's just showing sort of the progression. So starting in A, progressing to B and C and D. And so that's kind of how we work with our patients through these phases. Taking whatever they can do, whatever they can start with, and then building on that from there. Okay, so we talked about extension bias or extension-based exercises. Again, this is typically going to be your patient who has radicular symptoms that travel down the upper extremity for the cervical spine or the lower extremity for the lumbar spine. They centralize those symptoms with repeated extension testing. So when they do extension, like standing extension, prone press-ups, or cervical retractions, that centralizes their symptoms. And if they flex, that generally tends to peripheralize their symptoms. Again, if that movement testing does not affect their symptoms, if flexion doesn't make them better or extension doesn't make them better, this treatment approach should not be used. If your patient has a lateral shift, that needs to be corrected first, and then you can go into your extension-based exercises after that. Contraindications or precautions to using extension-based exercises would be any activity that would cause the patient to Valsalva. They need to be able to do these without that because Valsalva is going to increase their intrathecal pressure and continue to put more pressure on that disc protrusion. Active trunk flexion or rotation, because that is the opposite of what we're trying to do. That's most likely going to peripheralize their symptoms, and we don't want to do that yet. Or any movement. So if there's anything that peripheralizes their symptoms, they should avoid that movement or that position. If they have central nervous system symptoms, like I said, that cervical myelopathy or loss of bile and bladder, then again, they need to be further evaluated by their physician. Or if they have extreme pain and they're not responding to this, we want to, try something else with them. So here are examples of extension-based or extension-biased exercise. We do call them both things. So in this picture, this gentleman is showing a lateral shift. This is literally how a person may walk into your clinic. This is usually a sign of a herniated disc, and what the person is doing is they're sort of shifting away from that side. They're side bending away to open up that vertebral space a little bit more to give that disc more space to take away some of their pain. So if your person is shifted like this, you do need to correct that first. The PT should be doing this. There is a video link here that shows you how to do a lateral shift correction. It's not a very difficult maneuver, but that does need to be done before you have him try to do extensions. So if you have this patient trying to do just standing extensions or prone press-ups or anything like that, it's most likely just going to continue to hit on that nerve and that disc. So we need to correct his lateral shift first, and then we typically start with the prone progression. So the first thing we do is just have the patient lie in prone. You can put pillows under their hips if needed, because prone is going to put the lumbar spine in a bit of extension, and that may be too much for some people to even start off with. So if you need to, you can put a couple pillows underneath their hips, and then what we do is we just gradually start to pull those pillows out until the point that they are able to lay just prone on the table. Once your patient can tolerate prone, then we go to prone on elbows. Literally just have them prop up on their elbows in a prone position. From there, the next progression is a prone press up. So they will try to keep their hips down on the table, extend their upper extremities into a press up. And then we can also then have them stand and do a standing extension. So hands on the back of the hips and go into lumbar extension. The reason standing is usually at the end is because we typically have the patient start on the table first, because when they are prone, their spine is not loaded. When they stand up, they're now weight bearing through their spine. And so that is typically a progression then. We may have a patient who requires lumbar traction. So if it's tolerated by the patient, it can be initiated during the acute stage. Sometimes it helps, sometimes it doesn't in the acute phase. It should help in that it widens the disc space and reduces that nuclear protrusion. So again, we're talking about disc lesions. They should respond well to traction, but just keep in mind not everyone is going to. Just like discs should respond well to extension-based exercises, but not everybody is going to. So again, if they don't, move them into a different treatment category. Initially, treatment time should be relatively short, and intermittent traction shouldn't usually exceed more than 15 minutes. We need to use at least 50% of the patient's body weight. And if it is successful, they do have home units that can be prescribed for the patient. If they could not obtain one of those, you can also teach a family member or caregiver to do a single leg pull and have them do that several times throughout the day in order to help alleviate some of their symptoms. If someone has a disc lesion or herniation in the cervical spine, it is less common to occur in the cervical spine than the lumbar spine. The most common level is going to be C6, C7 because of the amount of motion there. In the acute phase, cervical retractions are the equivalent of a prone press-up for herniated discs. So doing cervical retractions or chin tucks, and there's a video link here to show you the proper way to do those, are designed to help encourage that disc protrusion back into its normal space. We're also going to do patient education with a focus on posture, and we may be successful with traction as well. So you can try that out and see if your patient responds well. If we have tried conservative treatment, if the patient has come to PT, if they've been taking medications, anti-inflammatories, and possibly even had some steroid injections, and all of those things are not alleviating their symptoms, then your patient may be a candidate for surgery. So again, surgery is usually a last resort. And it's when all other conservative measures have failed and the patient still has pain that is interfering with daily life. There's three. Your book mentions two common surgeries for disc lesions, and in that is going to be the laminectomy and the fusion. They do also have some discectomies now, which are usually for your smaller herniations where they can go in and just remove the portion of the disc that is herniated. When you have larger herniations, we're getting into these other types of surgeries. So a laminectomy is one surgery that can be done for someone who has a disc issue. So what they do is they actually come over, they remove the lamina, the spinous process, and possibly ligamentum flavum. So we do lose some of the stabilization at this spinal segment. So there is going to potentially be some hypermobility at this spinal segment. They can do a partial laminectomy where only part of the lamina is removed. And this is indicated over fusions if it's a small unilateral disc protrusion. The benefit is that you still maintain mobility and you get the person feeling better. So what they're doing here is they're just taking off this part of the spine to allow the nerve to have more room and take the pressure off that area. This is a picture of what a fusion would look like. So this would be indicated if there is axial pain with instability, if there are severe degenerative changes, or if there's uncontrolled peripheral pain. Usually larger, massive disc herniations, they may go in and do a fusion. The problem, I guess not the problem, but with the fusion, so here they have this vertebrae fused to this vertebrae fused to this vertebrae. So we have 3 vertebrae fused together. And this is what a fusion is. It's a metal plate with screws that now limit motion at those joints. So what's going to happen is you had your motion coming from all of these vertebrae. Now we fused these few together. What's going to happen is you're going to get hypermobility down here and up here to try to make up for some of that loss. So we're actually going to create hypermobility at the adjacent sites, and it's going to alter the overall spinal mechanics. Again, the benefit of this is that it's going to reduce mechanical stress, reduce the chance of additional herniations, provide more stability to the spine, and help to control the patient's pain, hopefully. So post-op management, if your person has a laminectomy or a fusion, again, patient education about any restrictions. Usually it's things like no heavy lifting. There might be some motions that they have to avoid initially. Wound management, there's going to be a surgical scar, and working on pain control. They are going to typically be in some pain, so again, using modalities and things at our disposal to help make them feel better. We may need to work on bed mobility with them. They may be braced. If it's in the cervical spine, they may be wearing some sort of cervical collar. If it was a lumbar surgery, they may be in like a thoracic lumbar type brace or hard sort of shell. So we may need to teach them how to get in and out of bed, how to perform ADLs while they're wearing that brace, which could last for several months potentially. As far as exercise goes, we typically don't give them a very sophisticated program at this point. We want to try to encourage just some walking, just to get them up, get them moving, get the blood flowing. And then if there's anything that can be performed in supine, non-weight bearing for the spine, just gentle exercises to keep them moving. Moving into the moderate and minimum protection phases, once the scar has developed, some scar tissue mobilization to make sure that they maintain mobility. For lumbar spine, again, the scar is going to be over the low back. For anterior or for cervical surgeries, sometimes they're going in through the anterior portion of the neck. So just keep that in mind, that their scar may be more anterior for cervical issues. We may do some stretching and joint mobilization. And when we say joint mobilization, we're talking just very gentle, which is grades 1 and 2. So that's really just within their available range. It's not into stretch or trying to gain new range. And we're talking about adjacent areas. You are never going to mobilize or manipulate at the level of a fusion. It's fused. They purposely tried to stop all motion there. So we're not going to try to introduce more motion there. We're going to do lots of muscle stabilization exercises. So this is, again, our core strengthening type stuff. I'm trying to activate all those muscles and maintaining good posture. And then we may do some gait training as well. So again, contraindications are going to be joint manipulations at the level of the fusion. And then if the person had a laminectomy, any type of extension-based exercise, because that spinous process is gone. So no prone press-ups for them. Okay, so flexion-based exercises. So these are going to be patients who feel better with flexion. So when they flex, that tends to relieve or centralize their symptoms, and they tend to get worse when they extend. This person may also have a lateral shift as well. So again, if they do, that needs to be corrected first before we have them flex, and you fix that the same way. So in that video that was on the slide, with the extension-based exercises, it's the same type of lateral shift if we're doing flexion-based exercises. So if we're doing flexion-based, we don't want to do extension with rotation, and we don't want to have that person perform any position or activity or motion that peripheralizes their pain. Again, these are going to be your patients who have diagnoses like stenosis, arthritises, your spondylolysis, and spondylolisthesis. So here's your flexion-based progression. So the first we usually start with is single knee to chest. Again, we're starting supine because supine is going to help us get our spine into a little bit more flexed position. We're going to start with bringing one knee up towards the chest at a time. So that's abbreviated CKSKTC. I can do this. And they can use their upper extremity to help support the leg. We can progress this to double knee to chest. And again, there are video links here to show you how to do all of these things. And if that's difficult, even using their upper extremities, I've sometimes put a physio ball underneath their legs for support and then had them just roll the ball towards them to bring their knees up towards their chest. Then they can also do seated forward flexion. In the video that's included here, it just shows the person seated in a chair, forward flexing at the trunk, bringing their fingertips down towards the floor. If your person needs a little bit more support than that, you can also do that exercise using a physio ball and doing ball rollout. So just put a big physio ball in front of them and have them roll that ball out forward and then back, and that will introduce trunk flexion as well. Then have them stand up. They can load their spine and they can do standing forward flexion as well, and that's just bending down towards their toes. Management guidelines for stabilization. Again, this is our stabilization, immobilization type of group who needs that core strengthening. So again, people who have hypermobility, ligamentous laxity, spondylosis or spondylolisthesis, which is again that fracture and then the fracture with the slippage. So here's pictures of that. So this would be where the fracture would occur. It's in the pars articularis part of the vertebrae there. And then because of that fracture, the vertebrae now starts to slip forward. This is spondylolisthesis. Okay. If your patient needs stabilization, bracing is not typically recommended. Again, they're going to rely on the bracing too much. We want them to be able to rely on their muscles to maintain spinal stabilization. So here is one big thing I want you guys to look at, learn, figure out how to do this. One of the foundations of all stabilization exercises, and this is called a bajillion different things, but one of the exercises, and your book refers to it as this, is called the abdominal drawing in maneuver, or ADIM. I've seen it abbreviated like this in a couple clinics. This is also the transversus abdominis exercise. It has a bunch of names: core bracing, ab bracing. So you can call it whatever you want to. I found this video, and there's a bunch out there. This is one of the things we need to do with most of our patients. It's one of the hardest things we're going to have to do with a lot of our patients, is teaching them how to activate their transversus abdominis. Practice it on yourself. If you kind of have some sort of mind-body connection, you can probably figure this out. But for some of our patients, this is a very, very difficult exercise to try to teach them. So try to learn some different ways that you can sort of explain this to them. I think this video that I included here does a pretty good job. So that is for the lumbar spine. For the cervical spine, we're going to teach them what we call capital nodding, which is a little bit different than cervical retraction, but it just helps to stabilize, stretch out some of the muscles that need stretch to help maintain a better posture. Osteoporosis. I found this picture and it truly amazed me. Looking at like your porous or cancellous bone and just basically what happens through the course of osteoporosis. And it's, when you look at something like that, it's no wonder they have such an increased fracture rate. So again, when we're treating osteoporosis, we can do trunk stabilization exercises, but avoid a lot of trunk flexion because again of the pressure that puts on the anterior vertebral bodies. We can do scapular stabilization exercises, right? Because they're going to tend to be in that forward flexed posture, the rounded shoulders, the increased kyphosis. So anything to try to open them back up and try to work on maintaining proper scapular position. Stretch the horizontal adductors, shoulder internal rotators, hip flexors, hip internal rotators. Again, these are the things that are going to be tight. We also want to do weight-bearing activities with them. So while aquatics might feel good and they could probably get some benefit, that's not going to be our treatment of choice for someone who has osteoporosis. We want to get them walking. There's even treatments, and we're going to talk about this later on in the term. There's a whole chapter dedicated to exercise for the older adult, and osteoporosis is discussed again in that chapter, but using like weighted vests and things like that just to add a little bit more weight for their bones. And then also instruct in proper lifting so they're not bending at their trunk when they lift. Treatment of spondylolisthesis. So again, remember, this is the slippage of one vertebrae over another. We do want to use more flexion biased or based exercises with them. We typically want to avoid a lot of extension. They are a lot of times in an extended spinal position anyway. They tend to present with an increased lumbar lordosis, so we don't need to keep feeding into that. We're going to need lots and lots of stabilization exercises. They need stabilization. There is a fracture in their spine, and we need to use their muscles to try to stabilize their spine as much as we can. Stretch their hip flexors, and you can do some gentle mobs for pain control. Again, we're talking grade 1 and 2 mobs. They're just real gentle to try to make them feel better. No high velocity thrust techniques with them. So no mobilization, grades 5, manipulations, anything like that. For treating ankylosing spondylitis, which is again that bamboo spine, we want to do some posture education. If it's at all possible for them to sleep in prone, we want to try to encourage that just to get a little bit of extension in the spine. Use a pillow behind their back when they're sitting, which will again put a little bit more extension in their spine, because when we sit for long periods, we tend to start to slouch and flex a little bit. We can do some gentle manipulations, grade 1 and 2, again, just for pain modulation. A lot of trunk stabilization, so core stabilization, scapular stabilization exercises, and stretching to maintain hip extension and shoulder flexion so that they can be as functional in ADLs as possible. And then treatment of Scheuermann's disease. Again, this is going to be similar to treatment for herniated discs, because this is when the disc can actually herniate up into the vertebral bodies above and below. And so they end up with more of an increased thoracic kyphosis because of that. So stabilization exercises, lots of scapular stabilization, postural correction, postural education, stretching of tight muscles, which is probably going to be like your pecs and a lot of the anterior musculature. And we may be able to do some joint manipulations or mobs to try to decrease pain and increase range of motion as well. All right, that's it for this one. Thanks.